I see all the board members. I see Mr. Becker, Mr. D'Onofrio. Are you with us, and are you doing the direct for Martine?
I'm still joining.
We're getting ready. We'll be right there.
Okay. Mr. Lee, are you with us yet?
Oh. And
I'm partially with you. I still need to get my backup on there.
Okay, yeah, just let me know when you're ready to go, and same for you,
Okay.
Blue Cross.
can you hear me?
Yes.
Okay. Give us 1 minute. We're just turning over the room. Thanks. We're ready. Thank you.
Mr. Lee, are you ready?
Not quite, almost.
All right. Are we good to go now, Mr. Lee?
Yes, I'm ready to go.
Okay, so let's go back on record, please. Mr. D'Onofrio, please call your next witness.
Thank you, Mr. Hearing Officer. Our next witness is Martine Brisson-Lemieux. Good afternoon, Ms.
Good
Lemieux.
afternoon.
Would you please state your name and your current position for the record?
My name is Martine Brisson-Lemieux, and I am the Chief Actuary at Blue Cross Blue Shield of Vermont.
And how long have you worked at Blue Cross as part of the actuarial team?
I joined Blue Cross's actuarial team in 2009.
Did you prepare and submit pre-filed testimony in this proceeding?
Yes.
And where does that sit in the binder?
My July 11 pre-file testimony is Exhibit 22.
Was all the testimony contained in Exhibit 22 true and correct to the best of your knowledge at the time you submitted it?
Yes.
And is that still true today?
Yes.
Were you responsible for preparing the filings under review here this afternoon?
Yes, I was actively involved in the preparation of the filings, and I'm fully familiar with all aspects of the filings and the underlying rate development.
And the documents that make up the filings are Exhibits 1 through 7 in the binders, correct?
Yes.
Did you certify the filings?
Yes. At the time of the filings, I certified that they meet all applicable and relevant actuarial standards of practice, and that they comply with applicable state and federal law and regulations. And that certification holds through today.
Similarly, were you responsible for preparing all of the information and responses that Blue Cross submitted in response to the questions received from the board and from the board's actuary and from the HCA?
Yes, the response were either prepared under my direct supervision or by other Blue Cross departments, and I'm familiar with all aspects of the material and can address in depth the material directly related to the assumptions and methodologies in the filing.
And those materials, I believe, are exhibits 8 through 14, 15 through 17, and 30 in the
Yes.
binders, right? Great. And have you had a chance to review exhibits 18 and 19, which are the 2 reports that Lewis and Ellis produced?
Yes,
You're familiar with those reports.
I am.
And each report contained 5 recommendations concerning the 2 markets currently being reviewed, right?
Yes,
And it's the same set of 5 recommendations in both markets, right?
yes.
What is Blue Cross's position with respect to those recommendations?
We disagreed with 2. Well, we have a notice of disagreement with 2 issues on the recommendations. It's exhibit 27 in the binder.
And okay, so and one of the items of disagreement had to do with medical utilization trend, right?
Yes.
Could you explain the disagreement there?
We disagree with the recommendation of reducing the utilization trend for mental health and substance use and specialty medication in the medical setting. The trend rates for those 2 service category has been higher than 4%, and we expect it to be higher than 4% through 2026.
And what was the other point that was raised in the notice? I'm not going to call it a disagreement because it was something else.
Right. It is not really a disagreement. So as in past years, right, LNE recommended that we update the projected rates for updated hospital budget information. And we agree that we should do that. And LNE said that we should also reflect the savings from Act 55. And we agree that we should do that. The reason we put in the disagreement is really to be able to incorporate our point that those savings, that those 2 components don't double count the savings around Act 55. And we address this really so that we can be clear around kind of our request that hospital budgets be clear around the implications of Act 55 on the commercial rate requests.
And did Lewis and Ellis address that topic? By that, I mean this double counting issue in the reports that they issued Monday regarding Blue Cross's AHP and large group filings.
Yes, they did.
And what did LNE say in those documents?
In both reports, they stated that the reduction for Act 55 should be included, but they note that it should not be double counted with changes in the hospital budgets.
You're familiar with section 1.3 of the actuarial memorandum, which is at page 3 of exhibit 1, right?
Yes,
And that section discusses the laws, regulations, rules, and other legal authorities that the filing must comply with, correct?
yes,
In your professional opinion, do the filings comply with all of those requirements?
yes,
And you're also familiar with section 1.8 at page 8 of exhibit 1, right?
yes,
That section addresses the criteria guarding this board's review under 8 BSA 4062, right?
yes,
And in your professional opinion, do the filings comply with those criteria?
yes, they do.
That concludes my direct. Thank you.
Thank you for the brevity of that. Mr. Becker, do you have questions?
I do. Hi, Ms. Brisson-Lemieux. How are you?
I'm well.
Great.
How are you? How are you holding up?
I'm hanging in there. Hanging in there. I'll also try to be brief. But at the same time, there's ground I want to cover with you. So I'm sure you're aware, you're familiar, there was a sharp drop in the Blue Cross small group enrollment from 2024 to 2025, down 31.6%, I believe, or 6,960 members. Does that sound right?
That sounds right.
Okay. And you're also aware, I'm sure, that MVP also experienced losses in the small group, and that across both Blue Cross and MVP, it was roughly 4,000, a 4,000 net loss to the small group market, or roughly 10% over 2024 to 2025.
I don't have that number, but I trust you.
Okay, thank you. At the same time that the individual market was up across both carriers, Blue Cross was up, I think, in the neighborhood of 700, and MVP was up in the neighborhood of 2,300 for a net gain of close to 3,000 people in the individual market. Do you trust me on that one as well?
I do.
Okay. So would it be fair to say then that from 2024 to 2025, that the premium shock of high premiums seemed to be contained to the small group? Is that a fair assessment?
Yes.
Okay.
Yes.
And now we're going from 2025 to 2026. We've been talking about this for years, but now it's finally here. We have to assume those enhanced premium tax credits are gone, and that not only is the cliff at 400% FPL back, but that the subsidies below 400% FPL will be reduced, and those people will have to pay more for coverage on average. Is that accurate?
Yes.
Okay, so you've modeled, and this is from page 13 of your actuarial memorandum, that 3,017 or 12.6% of the in-force individual members for Blue Cross will leave the QHP market in 2026. Is that accurate?
That's our assumption, yes.
Yeah, and so those 3,017 Blue Cross members, they're likely to be some of the healthiest members, yes?
Yes.
Okay. This sentence from Blue Cross's response to HCA questions already got a little bit of traction this morning, but I want to come back to it for just a second. This is Exhibit 17, page 4, and it's page 2, the response to question 6, and the language that was brought up earlier and discussed a bit, and I just want to focus on again for one more second. Eventually, without a reduction in healthcare costs, health insurance will not be viable for the majority of Vermonters, and the premium base will continue to erode, threatening the viability of the health insurance market. Is that observation essentially the definition of a so-called death spiral?
Yes, that can be one interpretation of a death spiral, yes.
Okay.
In the overall market, right? Usually that's used more on one particular carrier, one particular market.
Mm-hmm.
But yes, if we do not control the healthcare costs in Vermont, we're not going to be in a viable situation.
Okay. And so my last question on this topic is, when will we know that one of these markets, and let's just say it's the small group market, when will we know, what indicators will there be that that market is no longer viable?
I'm not sure, because a lot of the membership that we saw on the small group side, right, leave, found other coverage, other options, they have other options, or they went to MVP, right? And that happened, I believe, in 2018, where a lot of our membership went to MVP, right? And through the years came back, and it's been sort of this balancing, right, of back and forth between the carriers. But again, it's all dependent on the healthcare costs, right? If we do something about those, we as a state, not we, you and me, we can curve that pattern.
The costs are important, no doubt, certainly, right? Are there any other things that can be done? Any other regulatory mechanisms? The market structure? I don't know. My boss will probably be upset with me for saying this. Age rating. What if we brought younger, healthier people back into the market? Is that something we could do?
I mean, age rating is allowed under the ACA, right?
Mm-hmm.
And it's something that Vermont hasn't done for 30 plus years, right? But the theory of age rating is that yes, costs would be lower for lower aged members, but that means that costs would be higher for older members, right? So it's not a fix-all sort of situation, and a lot of modeling would need to be done to understand how many more younger members would the pool get, right? And if it would be worth it against the additional cost pressures that it would put on older members.
Okay, thank you. That's very fair, and I appreciate that. You are lucking out. I had a whole big section planned on the affordability templates. I'm going to skip over that entire thing, and I'm going to jump over. I want to ask you very quickly about the matched population methodology that you're no longer using. So, and this, matched population methodology, way over my head. So I just want to ask you some very simple questions about it. You said in the actuarial memo that you're no longer using this methodology because the matched population utilization statistics were not aligned with the overall population and produced results that were not reasonable. That's from page 19 of Exhibit 1. Does that sound familiar?
Yes.
Okay, and so from responses to interrogatories and L&E's memorandum, to me, as someone who doesn't really get it, it sounded like maybe the matched population was underestimating morbidity and thus utilization. Is that even close?
Yes, yes. So the results from the matched population, and we've used them for 22, 23, and 24, and 25, actually, for all of those filings. And what we are seeing now is while the theory is sound, right, the application gets complicated, and I don't have that many resources to really kind of dig into all the application. And what we have seen and our results show is that it has been under predicting the utilization trends for this market.
Okay, and I think I heard you say just now, and this was one of my questions, the number of years you'd been using it. It was, what were the years again?
I believe it's 22 through 25.
22 through 25. Is it fair to say that maybe the matching got less precise over time? Did that happen?
That would be fair. Yes.
Okay.
I think what's complicated with matching is that we can't rely on medical coding, right? We've talked about the coding intensity and changing in diagnostics. So we can't really rely on the medical coding to do the matching. So we have to rely on other things like the prescription drugs. But then as we match for 4 years, right, it is a little bit limited because of our size. Like I'm pretty sure that even if we could include everybody in the state, it would still have some limitation from a population size for that sort of analysis.
Okay, so I guess to conclude this section, underestimating morbidity and utilization, I mean, to me, could that not explain some of Vermont, Blue Cross Vermont's recent losses? Could a little bit at least?
Yes, we have missed on the utilization projections on top of other things that happen, right? We've seen more services that are getting more expensive, but utilization trend is one of the areas where we did not expect to see a 5% utilization trend year over year, right? And I'm still honestly surprised that our actual results, that's what it was. Or very close to. So that was really unexpected. And I don't know that even if we had used the full population at that time, I don't think we would have been in a place to project how high the utilization trend has been over the last year.
Okay, all right. I'm going to pivot to my final section, and hopefully this will be quick, but it's my favorite topic, prescription drugs. So, okay, all right. And I'm going to start just with H266 or Act 55 as it's now known. This was the legislation that was passed this last year that caps the reimbursement of outpatient administered drugs at most Vermont hospitals. It's 8 out of 12, I think, right? To 120% of the ASP. Is that right?
Yes.
Yeah, okay. And if I recall, and I was paying attention to this, Blue Cross was very much in favor of H266. Is that fair?
Absolutely.
Okay. What were some of the reasons why Blue Cross supported H266?
I think the main reason is that we saw how expensive we were compared to everywhere else, right? We saw the RAND report. We saw a few other studies that showed that Vermont was #1 on most expensive, which is not a place where we want to be. And so and I think it's also a very concrete thing we can do. Right, it's kind of a limited scope in per se, right? There's so many medical codes, right? Like medical billing is, it seems like it's infinite, but having that specific place where we can have a specific benchmark with the ASP and we have clear evidence that Vermont is an outlier was I think one of the reasons why we really sort of focused on this piece right now.
Excellent. So you mentioned that specific benchmark, ASP, and now that is a specific benchmark, and it's collected by CMS for use in Medicare. Is that right? Or it's established by
I'm not
CMS
sure.
for use in Medicare? Okay, but it is a specific benchmark, yes?
It is a specific benchmark, yes.
Okay, in those pricing files, they're readily available to the public online, right? You can just look up ASP and you can find those pricing files. Are you aware? Did you know?
I did not know, but I'm assuming that they're available somehow. Whether it's easy or not, I don't know, but I know that they are available.
Okay, and you don't have to pay a subscription like you do for something like AWP, for example.
I don't know. I don't think so,
Okay.
but I'm not sure.
Okay. Would you agree that ASP is roughly equivalent to a hospital's actual acquisition cost for those drugs?
Well, ASP stands for average sales price, so I would think that that's what it is.
Okay, all right. And as such, capping reimbursement at 120% of ASP, there's some logic to that it would reimburse hospitals at their acquisition costs and then give them some margin, right, for storage, handling, administering, et cetera. Was that sort of the idea of setting it at 120?
I don't know why it was set at 120, and I don't know what the hospital's acquisition costs are.
Okay, all right, fair enough. I'm gonna take you to Exhibit 17, page 6. These are the responses to HCA questions. And we asked you to provide 3 lists of 25 drugs, the 25 most frequently dispensed, 25 highest allowed charges, 25 highest year over year, and then to give us the AWP per unit and then the NADAC per unit for those drugs. So that's Exhibit 17, page 6. You recall these tables?
I do.
Okay. Of the 2 prices we asked for, AWP and NADAC, which of those in your mind is most similar to the ASP in that it's roughly equivalent to a drug's actual acquisition cost?
I don't know.
Okay.
But I would think my understanding of NADAC is that it's related to Medicaid pricing, but I had never looked at it until you asked the question.
If I told you that NADAC stood for National Average Drug Acquisition Cost, would you believe me?
I believe you.
Okay, all right. Your PBM contract is not based on NADAC pricing, is it?
No.
And you do not
it's based
develop
on AWP.
AWP. You don't develop drug trend based on NADAC pricing?
We do not.
Okay, so your trend, your pharmacy reimbursement, your ingredient costs, all of that is based off of discounts off of AWP, right?
Yes, I believe there are some exceptions for some generics. There's other, I think it's usual and customary, right? UNC. So,
Okay.
but the majority of the claims are AWP.
just looking at these tables and just do the top 25 most frequently dispensed and go down those two columns, AWP per unit and NADAC per unit, can you observe any relationship between the two?
No,
No.
it seems
No.
like there's no, if we were to do a graph, there would be no correlation.
No clear relationship, no correlation at all between the AWP and the NADAC. I'm curious, and this is a genuine curiosity, and maybe this is more than you can answer right now, but this has been something that's been on my mind since I've been doing this work. Wouldn't it create distortions when predicting trend to use AWP if it has no connection or an uncertain connection to what the drug actually costs, if you'll accept that NADAC is close to representing what a drug actually costs?
Well, so what we pay is based on AWP. And so for our purposes and what the ingredient cost ends up being for this line of business, AWP is the best metric because that is how the claims are defined.
Okay, I think I can understand that. I'm going to want to explore this further with you, maybe at some other time. I just have one little small section of questions, and then we'll be done.
Okay.
Again, looking at this list of the 25 most frequently dispensed drugs, Blue Cross's ingredient costs, which you're actually reimbursing pharmacies for. I know your trend is based off AWP and getting a discount off of AWP, but what you're ultimately paying it's closer to that NADAC price. Is that fair? Do you know?
I don't know because brands and generic have different discounts. And so the AWP, sort of the ingredient cost, which is the AWP minus the discounts, would be different. And so the answer would be different for brand and generics.
Okay, and it's clear from this first table that these are all generics. It sounded like you were willing to accept the premise that NADAC is close to what drugs are acquired for. That's the cost of the drugs for the pharmacy. And if you'll humor me, I mean, I went ahead and divided the allowed charges by the number of scripts. And I can tell you that your ingredient costs are closer to, much closer to NADAC than they are to AWP. And just because I know everyone's ready to move on, I'm going to sort of ask my final question in a way where I'm like giving away the point I want to make, which is, imagine you're a Vermont pharmacist filling thousands of prescriptions for atorvastatin or omeprazole for, 4 cents per unit or 3 cents per unit, literally pennies. And do you know what your dispensing fee is to most pharmacies? Is it $1 per script?
No, it's very small. And I
It's
believe it's for some brands. Yeah.
Okay. So just imagine you're a pharmacist or you're a pharmacy trying to pay your bills. I mean, how does this model work? And it's unfair. Like I said, I'm asking a question where it's clear a point I'm trying to make, and I'm not going to ask you for a response. And I'm just going to wrap it up right there, if that's okay with everyone. And I'm sorry. I appreciate it for you humoring me with this exercise.
Thank you, Mr. Becker.
All right.
Moving on to board questions, starting with board member Holmes.
Great. Thank you so much. I know it's late in the day. I think we're all tired, so we're all gonna, I will do my best here. Long day. So it's good to see you again. Thank you for your testimony and for
Yes,
coming
yeah.
and all the work that I know that goes into putting these binders together and answering all of our questions. So I do have some, what I hope are actuarial questions for you. And you may even be able to anticipate this question because I asked the same question on Monday, but this isn't with regard to the individual market with the 6.6% premium increase that's related to the sunsetting of the, the tax credits, estimating about 16% are going to exit. Yeah. So I looked over, the analysis there, and you've got a simulation model that's built on a lot of assumptions, about human behavior, speculation about the underlying health, and, there's a lot that goes into this. And I know you ran about 5,000 simulations that had varying retention rates. And so I'm not going to spend a lot of time, given the late in the day, asking you all about those various retention rates and how they were assumed, but 6.6 is 1 point estimate, and I assume that there's a confidence interval. So, and I'm sure you're prepared for this, or I'm hoping you're prepared for this question. What is the confidence interval around that?
Right. So we don't do our estimates in a way that I can give you a confidence interval, right? That is not really how we go about our process. But there are more than one answers in some of these assumptions. And this particular one is absolutely one where, right, there's a lot of unknowns. We don't know how members are going to react, right? We don't know exactly how it's all going to come together. But when we set our assumption, right, one of the things we looked at is, we said, okay, our methodology is sound. We ran simulations, which gave us a range, right? And I don't remember what it was. And then we looked at what was happening outside of just us, right? Because it was like 3 of us trying to figure it out. And of course, like, we don't have all the knowledge. So we looked at what others were doing, right? There was a Wakely study that was done for the state last year. They had an estimate. There was some estimates, public estimates by Oliver Wyman, right? And I participate in Blue Cross Association actuary forums where some consultants come and present, sort of national information. And so we had all that in mind when we picked a point estimate, because we have to pick a point estimate, right? I can't give you a range of rates. So I don't have sort of per se a confidence interval for this particular assumption. What I know is that it's in the range of other numbers that have been put out there for the same assumption. But this is part of the risk we're talking about today, right? There's a lot of uncertainty. There's a lot of risk. This number could be 10%, right? And there could be a lot more members that leave. There could be a lot more disruption. So we have to sort of keep that in mind when we talk about sort of the overall risk that we're covering with our premiums.
Okay. Well, I think it's at one point you said you did 5,000 simulations and you came up with a range. So perhaps if you go back to that work, you can share what that range was. I recognize you may not have it right now, but it would be helpful to see somewhat more around what those estimates looked like. And you're right, there are a lot of estimates out there. I think Oliver Wyman came in at 5.9. I think KFF just published something that said it was about 4%. I think the Urban Institute came out with something last year that was 5. So the 6.6 is on the higher end of some of the things that I've seen out there. So it would be helpful to get a little more information about the assumptions specific to, your estimations. Oliver Wyman is a national study, and one of the things that, it represented was that young people are the most likely to leave, Blacks and Hispanics are the most likely to leave. So there's a lot of features about the national population that may not actually reflect our population here. We have an older population, we have a largely white population, we have a healthy population, right? So there's a lot of things that might not marry up against some of the national estimates. So it'd be helpful to understand that a little bit more. I wondered how else you're factoring in some of the other features of this big, not so beautiful act. In particular, my understanding is that there's an end to the income-based special enrollment periods, and those allow lower income people to enroll at any point during the year, which I imagine would be a triggering event, would be their health, something in their health that, forces them to enroll. So how does that impact the morbidity assumptions that you might make if low income people can no longer enroll at any point during the year?
So we did not make a specific assumption around changes in morbidity for all the changes in the in the enrollment process that was going to happen. There was uncertainty around the effective dates, right, at the time that we were all doing this work, or that even some of the provisions would go through. So we don't have specific assumptions around impacts of those changes or impacts that that bill did to Medicaid, right, and how that could all flow through. We don't have any of that in these rates, which really, again, to my point, there's a lot of uncertainty around how this whole market is going to be and is, you know, what's going to happen to it, right? And so we have to be really mindful about all of the projections.
Okay. With respect to 266 or Act 55, does your analysis make any assumptions about patients moving towards a lower cost facility with respect to these, you know, basically now that they can, you know, move to a facility that has 120% cap versus where they're currently receiving their infusions, say, for example?
No, we didn't include in our estimates sort of membership shifts from where they are currently getting their care, right? So to calculate our estimates, we looked at our experience period and capped that, right? And then added all the projections. So there's no assumptions around members choosing a different facility or facilities choosing a different site of care or any of that, sort of those things that can happen.
Okay, so in some sense, there could be an underestimate of the impact of Act 55 if some patients that are facing high cost sharing can switch now to hospitals that have, you know, these drug caps, or Blue Cross Blue Shield could potentially steer patients that attend right now, get their infusions at Dartmouth Hitchcock, which is not going to be impacted by the drug cap, to say a Mount Scottney or a Brattleboro that would be impacted by the drug cap. So there is opportunity potentially for some patients receiving the care at some of these higher priced hospitals to move and benefit from these drug caps.
Right, and there's also opportunities for new members to decide to go to Dartmouth because that's the best thing for their care as well, right? I think the opportunities around the caps are go both ways.
Okay. Another question around reinsurance. So I noticed that there was one individual member who has very high drug costs that are not covered by reinsurance. I believe it was about $1.85 million in claims for this one individual that had to get factored in its entirety without benefit of reinsurance. And I wondered if that individual would be potentially impacted by this drug cap and whether that might actually lower that addition in the rate.
Unfortunately, no, because this particular member on this particular drug is through the pharmacy benefit. And it is a very unique, I would say, right? It's what they call like orphan drugs, right? And so this particular member is not impacted by this cap, but we do have the high cost risk pool, right? So while they are excluded from corporate reinsurance, they are eligible for the federal high cost risk pool. And that is reflected in the rates.
Great. And then I guess I was also thinking about reinsurance in general. A lot of it seems as though some of the potential need for reinsurance might be mitigated by this drug cap. Is that possible? That this drug cap could be really reducing some of the claims costs for some of these high cost claimants who were, you know, utilizing these very expensive drugs on a regular basis? Would it have any impact on the premium for reinsurance with this drug cap?
Possibly, but that would be up to our reinsurer, right? There's a lot of other claims that are really, really high. So I don't know exactly the proportion of the claimants that go above $1 million that are because there are some on these drugs, right? There's other reasons why you can go above reinsurance.
Yeah, it'd be really helpful if you could look into that, just because to the degree that it actually reduces the premium for reinsurance or the need for reinsurance, it might impact these rates, right? This drug, I'm thinking these drug caps could flow through to other areas besides just the expense there, the pharmacy expense. I'm trying to see if there's other questions here I have. Yeah. There is, so Act 111, I know, and I talked a little bit about it this morning, but you know, it does there it is you've adjusted the QHP rates upward to account for these higher costs of claims stemming from the restrictions on, you know, utilization management, largely prior auths. But we also know that prior authorizations can delay care. They can require, you know, intermediate steps that are costly but ineffective, and they can encourage more ED visits if people can bypass prior auths by going to the ED. So I'm wondering if any of your calculations make any adjustments for the reductions in delayed care, you know, the reductions in the total cost of care that could materialize as a result of the elimination of some prior auths.
So I don't have data around what would have happened if a member had had that prior authorization and in what they consider a timely manner. So that is not something we can really estimate, right? And so it's not something that's included in the rates.
Okay, so do you know how many people, for example, go to the ED to avoid prior auths?
I don't. That's not part of the information we have.
Okay. And then I guess my last question is around, and we brought this up a little bit earlier today, but trying to really understand when you submitted the rates, there wasn't really an understanding what the other carrier is going to submit. But now we know there's a sizable difference between the two carriers. So how would you update the model to account for the relatively high request that Blue Cross Blue Shield has relative to MVP? How would it change, for example, the projected QHP membership, and how does that flow through the model, seeing that differential and understanding people's price elasticities there and switching?
Right, so we don't have that information when we do the projected claims, and we never have it right on time. And really what's difficult is that, as we've learned this year, right, the rates that are filed are very different from the rates that end up being approved. This year being, you know, Act 55 was this thing we did not know, and now we're putting in. And so we have not, we usually wait to see what final rates are to do our projected membership forecast, because so much can happen between May and August.
Okay.
But we'll do that work for the financial forecast, and usually in the fall, once we understand and once we can work with the sales department to understand how they think that these rate relationships will impact membership.
If there is a large exodus from Blue Cross Blue Shield towards MVP, and there's a loss of membership, how does that impact the need for member reserves?
It doesn't. Member reserve is a percent of the total projected. And so it would be 7% of a smaller amount, but it would still be 7%.
If your membership shrinks, there's less pressure on the full surplus, right?
The RBC formula will be adjusted because volume, yes, but there's still a lot of risk and uncertainty.
Okay. Okay, those are all my questions. Thank you so much.
You're welcome.
Chair Foster.
Yeah, hi, Ms. Brisson-Lemieux, nice to see you. You have some data available at Blue Cross Blue Shield for fiscal year 25, is that correct?
Yes.
And how would you characterize what you're seeing year to date in hospital claims in 2025 vis-a-vis what you experienced in 2024?
We are not experiencing a surge like we did last year, right? So for our insured lines of business, which is what I have in my brain to remember right now, the 2025 incurred claims are as we expected in our forecast, right? And the forecast is what we have talked earlier. That is not what we had thought when the rates were approved, right? So we are targeting to have our claims be at the level that we expect will generate approximately 4% contribution to reserve, assuming the second half of the year continues to behave the way it has so far.
Okay, I'm gonna go to exhibit 15, page 21. It has a table by hospital with variance to target for 24 and fiscal year 25.
Yes.
In preparing your rate request, did you consider the fiscal year 25 performance at all?
So no, right? So when we do the rates, we take 2024 experience and project it through 2026. And the cost increases for Vermont Hospital, well, for all hospitals, all right, were the ones that were agreed upon for 2025. But we didn't have year-to-date information to see how those were under over and to reflect that.
But you didn't look at what's happening in 2025 to pressure test your assumptions when you projected from 2024 to 2026. Is that fair?
Right, we had 2 months of data of completed data when we filed. It's not reliable.
You now have more months of data and you have more reliability in that data. And are you planning to make any adjustment or to consider the fiscal year 25 performance in projecting your claims for 26?
At this point, from what I'm seeing so far, there's nothing that warrants a change in my projection.
And why is that?
Because 25 is tracking with where we were thinking it was going to track. And so the increase that we need, right, is really, it's like a year of trend and a few other things, but I don't have a reason so far to think that the sort of implicit 2025 in the 26 projection, right, because it's a 2-year thing, is not very different from what we're seeing year to date emerging with our results.
Are you aware of the Care Board's settlement with the University of Vermont Medical Center?
I am.
And is there any component of that settlement that would impact fiscal year 26 rates?
Yes, so we did reflect part of that settlement in the projected cost trend, right? And so my understanding in the settlement was that the remainder of the FY23 enforcement, which was $40 million, right, was going to be split between fiscal year 26 and 27. And so when we did our projected cost trend for 26 for UVM, we reflected the expectation, right, that a baseline of 3% for the guidance would be reduced by that $20 million, give or take, for the enforcement. And I know we put a table in the binder. I cannot remember which exhibit it's in.
Settlement agreement also requires UVM to appear before the board for a mid-year adjustment. Is that reflected in your rate requests?
It is not, because that is a 2025 event.
You know what the settlement required UVM to do with regard to a fiscal year 25 overage?
My understanding is that they were supposed to come to you with a mid-year rate reduction.
So, and why is that not reflected in 26 rates? It would reduce the price per the settlement agreement. Why is that not in the rate for 26?
Well, at the time of filing, and really up until Monday, we had not seen anything around what they were proposing to the board, right? So at the time of filing, it said, if we are over, we will come with a mid-year, which is great. And we're really happy that it's happening. But at the time of filing, we had no information to know that they would actually be over.
Got it. And do you know by how much they're over for fiscal year 25?
Not exactly, but I understand that they filed a document with you that explained that they were over and that they were intending to change some reimbursements.
And then there are fiscal year 24 enforcement actions that are potentially before the board as well, relating to CVMC and Springfield. Do your 26 rates reflect the potential for enforcement for those hospitals that were over in 24?
They do not, because we did not have that information at the time of filing. It's my understanding that those will be addressed through the hospital budgets process. And we agreed that we should update for hospital budgets. And so I expect that that will all kind of flow through that way.
And then do your rates for 26, your request, do they reflect the hospital budgets that were submitted to the board?
They do not.
So on exhibit 15, page 21, do you have more current data for UVM? At the time of the submission, you only had 3 months experience for fiscal year 25. Do you have more current data now?
So we need at least 3 months of run out, right, to do this analysis. So we sit here in July, so we have June data, right, completed June data right now, which means that we can only use anchored through March for it to be complete and usable for this information, for this analysis.
Sorry, so why do you have 6 months for everybody but the UVMHN hospitals?
Their contract with us is on a calendar year basis. All other hospitals have a October 1st start date.
Oh, I didn't realize that. Has that always been the case?
It has changed in the last 15 years I was here, but I cannot tell you when.
Okay.
But it's been more than a few years.
Okay, thanks. Are you familiar with the term monthly relativities?
In what context?
In the context of medical claims?
I'm not sure I understand the context. Sorry.
In terms of the context is evaluating how the medical claims appear relative to, I think it's relative to forecast.
Oh, yes. So actual to expected on a monthly basis. Yes.
Yeah. And have you looked at those for fiscal year 25?
We have.
And could you provide that data to the board?
Yes. Yes, we can.
And was there any consideration, or sorry, was there any impact on the fiscal year 26 rate request from what you saw in the monthly relativities data?
Not from 2025, because again, at the time of filing, we did not have 2025 data. And so far this year, I don't, it's not tracking to a place where it would make me change my answer for 26.
Responsive member Holmes, you discussed the analysis that was done on morbidity. And my understanding is that it's Blue Cross's position that morbidity will increase due to the additional cost that members will have to bear if the APTC credits go away. Is that correct?
That's correct.
Did you perform any assessment on morbidity that would be associated with a 23.3% rate increase?
Not beyond the factor that we put in for the expectation of members leaving for the changes in APTC.
Okay. Why did you not do an assessment for the impact on morbidity for members leaving due to a rate increase?
So when we set the rates, we have to do a claims projection, right? Which is the vast majority of what I do and the rates, right? And I don't know what MVP is going to file, right? And I can't do sort of what if scenarios that get me into the circular reference, right? If the increase is lower than this, if the increase is higher than that, what we can do is at the time of the filing, our projected claims costs for the members that are with us, right? Sort of putting aside one-time items like the expiration of subsidies. That is the work we do.
Okay, is there something different about the expiration of subsidies and the dollar implication for members in that's different than the financial implications of the 23% rate request?
So that was a one-time item that's coming from an external force, right? And so it is impacting the whole market, right? The information I don't have is what the competitor is going to do.
I see. It seems like it's two things, right? People could move to the competitor, people could drop, or people could buy down, right? There's a couple different options, not just the competitor. I guess what I'm getting at is, do you agree that you may have increased morbidity due to a 23% rate increase?
Yes, there are some possibilities where members will choose to for another options, whatever that is, because of the increase. But I just want to be clear that we are no longer asking for a 23% increase, right? We will incorporate the changes for Act 55. And that alone, right, brings the rates down by about 4%. And we will incorporate the updated information around risk adjustment, which also brings the rates down.
The numbers move, and there's a lot of numbers. What's the current request?
So we talked about this internally. There's no current request because of the uncertainty around how to incorporate the hospital budget, right? In prior years, we did sort of a request at hearing because the hospital budgets and the interconnection with Act 55 were not sort of creating this situation where we're really not sure kind of how they go together. But if we use LNE's report as our basis, right, even though we have some small disagreements, I think that is sort of where we can have our minds on the increases. And for individual, it's for the LNE report, it's 15.5.
How certain is Blue Cross that the enhanced subsidies will not be renewed?
As certain as anyone can be on this call around what the federal government can do. So I don't know, right? My understanding is that there is still a possibility that it will happen. But so I don't know, which is why we submitted 2 sets of rates.
Is there a chance that the subsidies, if they were to be not renewed, that they're phased out more slowly and over time?
I guess that's an option.
All right, I'm gonna move to the drug price cap bill. You had mentioned a 4% rate decrease approximately due to the drug price cap bill. Is that right?
Yeah, combined for individual and small group.
What do you mean combined for each?
So the individual market will have a slightly larger impact and the small group will have a slightly smaller impact. So if I put the two together, it's about 4%. But it's really like 4.1 for the individual market and I think 3.3 for the small group market.
Going to exhibit 15, page 17.
Yes.
Question 9, quantify the impact. Do you see that?
Yes.
Then the second paragraph reads, quote, using the methodology described in response to question 8, we estimate that a cap of 120% would lower the average rate increase from 13.5% to 9.7% for small group and 23.5% to 18.4% for individual.
Yes.
Can you explain? So that to me, 23.5 to 18.4 is 5.1%.
Yes, when I compare increases, I divide them. I don't do subtraction, but those are the same numbers I was using.
You're gonna have to walk me through the math. I mean, it says the request was
Yeah, absolutely.
23.5, and say
really,
now the request would be 18.4.
so the math we do when we do changes and increases, really, it would be 1 plus 18.4% divided by 1 plus 23.5%.
Okay. Get that.
But in total, it's all the same. We're all talking about the same thing, right? We're talking about the $20 million that this would save this combined market.
Maybe it's a language issue here with the answer, because the answer says the average rate increase would go down to 18.4 from 23.5.
That's correct.
So your testimony is the impact of the drug price cap bill would not be down to 18.4, it'd be down to 19.4.
Oh, I misspoke. It is 18.4. Sorry.
Okay. All right. Your methodology only included the top 50 most expensive drugs. Is that correct? Sorry. What drugs did your methodology include?
All drugs that have an ASP
All
that
drugs,
are
not
dispensed in outpatient or professional setting. Sorry.
all drugs, not just the top 50.
Correct.
Seem to have a memory that in the legislative session, Blue Cross had submitted a letter and said it would be about 4.1% decrease in commercial prices for the top 50.
At the time of that letter, it was those estimates were done at a much higher level, right? And not necessarily as specific as these estimates that we do for pricing purposes.
New biosimilars and generics come on the market every year, is that correct?
That's my understanding, yes.
And ASPs can go down with the entry of a biosimilar to the market?
I suspect it does, but I don't know for sure.
Okay. Did you do any analysis in coming up with this calculation of the impact of new drugs entering the market?
No, we used the ASP that was available at the time we did the calculation.
Did you look back to see in prior years how many ASPs decreased throughout the course of a year?
No.
So if a drug had an ASP, so in the legislation, it requires hospitals to check and adjust ASP twice a year, correct?
I think so, yes.
And so ASPs can move throughout the year, and I presume that they have moved throughout the years historically. So if an ASP goes down and you're paying 120%, you're now paying a lower amount, correct?
In that one specific case, yes.
So in some sense, the estimate here is incomplete.
It's the best we can do with the information we had and the time we have at the time.
You said you reviewed, or maybe it's you tested that the Blue Cross request complies with all relevant Vermont laws. Is that right?
Yes,
And did you review 8 VSA 4062?
yes, although I don't know all the numbers by heart, but I did review, I am familiar with the Vermont laws.
Okay. So 8 VSA 4062 and 18 VSA 9375 are the standards by which the board needs to conduct its job here in this space. 4062 is determining whether a rate's affordable, promotes quality, et cetera, et cetera. 9375 requires the board to execute its duties, including in connection with rate review, consistent with the principles of healthcare reform expressed in 18 VSA 9371. Did you review 18 VSA 9371?
I am familiar with those laws, yes.
And did you review 9371 to determine whether or not this rate request is consistent with it?
The rates comply with all Vermont laws, yes.
It looks like Ms. Green provided some testimony kind of generally about the healthcare market in Vermont and the affordability issues. And I think she'd said the silver plan on Blue Cross for family of 4 would be north of $55,000 if these rates at 23% were approved. I think last year we had a 15 to 20% rate increase. The year before, double digits. This year, potentially being requested 15 to 23, something like that. Do you think this is a sustainable way to finance our healthcare system?
I think there's probably better ways to finance the overall healthcare system.
So I just want you to specifically answer my question. My question is, do you think these rates and the rates that we've approved in recent years is a sustainable way to finance the healthcare system?
I don't know that I can answer that question.
Why or why not?
That seems beyond my area of expertise.
That's one of the legal requirements, and you testified that you certified that these rates comply with all Vermont law.
Right, and I rely on other experts to help me say that these rates comply with all Vermont laws.
Okay, so your attestation is based on what other people told you?
Yes, I relied on other experts to help me ensure that the rates we file follow all the laws.
And who did you rely on to determine that this is a sustainable way to finance the healthcare system?
Well, we have attachment D, which is exhibit 4, right? We have a letter from our chief medical officer and our chief financial officer addressing the non-actuarial standards in rate review.
I don't recall that addressing the sustainability of the financing of the healthcare system. So
I'm not sure I'm following the question.
Yeah, I'm not trying to like put you on the spot, but it's a fair question. It's part of our rate review standard that these rates need to comply with all Vermont law, and the law specifically references 9371, which is the principles of healthcare reform, which includes a requirement that it's a sustainable financing of the healthcare system. And you testified and asserted that these rates do, and then you testified that you relied on other people. But it doesn't seem like you know who that would be as to this component of the rates, the sustainability requirement. And that's okay. I just want to know the answer.
I don't remember specifically reading about sustainability of the financing of the healthcare Vermont.
Okay.
In Vermont.
Right. Another component of 9371 talks about the requirement that costs be contained and unnecessary expenditures I don't have the exact language in front of me, but that there's mechanisms to remove unnecessary expenditures. Do you have any information as to how these rates comply with that requirement?
I'm sorry, can you please repeat the question?
Yeah, let me see if I can get you the exact language. It might help. So it's 937110. Vermont's healthcare system must include mechanisms for containing all system costs and eliminating unnecessary expenditures, including by reducing administrative costs and by reducing costs that do not contribute to efficient, high-quality health services or improve health outcomes. Efforts to reduce overall healthcare costs should identify sources of excess growth. So my
Yeah, so
question
cost
is,
containment.
yeah, sorry, go ahead.
Please finish your question, sorry.
Yeah, my question is, what did you do to confirm that these rates comply with that requirement?
So that's a lot of cost containment, right? And we do a lot of that. We do payment integrity. We have a thorough process around prior authorizations, right? Where they are reviewed to make sure that the effort spent on them is worth the, outcomes. We have value-based payments that work with the providers to enhance quality. So we do a lot of those programs, and we revisit a lot of the things we do on an ongoing basis to make sure that we're spending our efforts in the right places.
Does Blue Cross at all look at or ask hospitals about their expenditures and whether or not they have unnecessary expenditures in their budgets that these rates contribute to paying for?
I don't think so. That is part of the hospital budget, is my understanding.
My view is it's also part of the rates, and that there needs to be an effort to make sure that the rates aren't going to support unnecessary expenditures pursuant to these laws. But I appreciate your testimony today very, very much, and thank you for being here. I have nothing else.
Thank you.
Board Member Walsh, do you have questions?
No, I think Chair Foster's the questions he just finished cover everything that I hope to know more about at this time.
Board Member Merman?
I don't have any more questions. Thank you, though.
Mr. D'Onofrio, do you have any redirect, or do you need a minute to figure that out?
Yeah, I'd love 2 minutes. I can just mute the line here and go off camera, or we can take a 5-minute break, whatever you like. I'd just like to, my notes are all over the table.
Yeah, why don't we target 4:50 to start again?
That's fine. Thank you. We're ready when you are.
Mr. Miller, are you ready to go?
Good to go.
Okay, go ahead, Mr.
Okay,
D'Onofrio.
I have a couple, thank you. I have a couple just very limited questions on redirect. So you were asked some questions, Ms. Lemieux, about member movement based on the carrier's relative rates. Do you remember that?
Yes,
So estimating that sort of member movement at the time that you develop these rates, it's an unknown, right?
right,
So you're unable to account for it at the time you're developing the rates, right?
right.
So it's a source of uncertainty.
It is.
And as a source of uncertainty, is it the sort of thing that reserves are designed to protect against?
Yes,
Okay. You were asked some questions about potential hospital mid-year 2025 budget adjustments. Do you remember that?
yes,
So if hypothetically, if a hospital implemented a mid-year 2025 budget adjustment that was limited to, its effect was limited to calendar year 2025, and that was implemented on August 1st, 2025, would that be able to affect your 2026 rates?
no, if the intended impact was limited to 2025, then it would not impact the projected claims for 2026.
Would you please turn to page 3 of Exhibit 1 in the binder?
Yep.
Do you see section 1.3 entitled Scope and Purpose?
I do.
And do you see the list of laws, regulations, orders, and guidance listed under the words, "This filing is intended to comply with the following laws, regulations, orders, and guidance"?
I do.
Do you remember you were asked some questions about some provisions of 18 VSA 9371, which I'll represent to you is entitled, it's a statute entitled Principles for Healthcare Reform.
I do.
And do you see that statute listed on the list under section 1.3?
No.
And that list, those are the legal sources that you're certifying that the filing complies with each year when you certify the filing, right?
Yes.
I have no further questions.
All right, so we are at time for today. We have 3 more witnesses to get through: Kevin Ruggeberg, Andrew Garland, and Mike Fisher. We have held time for tomorrow. We only have 3 hours, 9 to noon. All the board members are available with the exception of Dr. Merman, who would have to watch the recording. I had heard from Mr. Becker that he and Mike Fisher are available. I don't believe I ever heard from you, Mr. D'Onofrio, about Andrew Garland. I expect that you all are available tomorrow from 9 to noon
Yes,
to continue this hearing.
Yes, I apologize if I never got back to you, Mr. Barber. We are available.
Okay. So then I would propose that we continue the hearing till tomorrow morning. And start again with Kevin Ruggeberg, who I understand is available at that time, starting 9 o'clock. Kevin, are you on the line? Can you confirm that, please?
I am available.
Okay. So we have 3 hours, 3 witnesses. I'd like to establish some expectations around how quickly we can get through those 3 witnesses.
Today.
I'm sorry, what was that?
Sorry.
So I'm anticipating 1 hour for Mr. Ruggeberg, 1.5 for Andrew Garland, and half an hour for Mike Fisher. Does that sound reasonable? Can we all try to stick to that? Everyone?
Mr.
Board
Barber,
members?
all I can offer by way of information on that is I have a very short direct plan for Mr. Garland. And possibly some very limited cross for Mr. Ruggerberg, depending on his direct testimony.
And in that same spirit, I have nothing for Mr. Ruggerberg, so we should be pretty good.
Okay. I appreciate that. Is there anything that anybody feels we need to cover before we jump off the line? I don't, since we're continuing this, I wasn't planning to take public comment, but I'm happy to do that if Chair Foster, you think that's appropriate at this point?
Yeah, I had one follow-up to, in response to the redirect by Mr. D'Onofrio, just, it'll take 1 minute. And my question was, so Mr. D'Onofrio asked you, Ms. Brisson Lemieux, about the laws referenced in Exhibit 1, page 3. And this may not be something you can answer, and I totally appreciate this. I'm presuming that somebody else prepared this, or this was a list from a prior filing or something like that. But I have to ask you because you're the witness. Do you know why 18 VSA 9371 is not referenced in this list?
I don't know why.
Okay.
But this is the list that we certified to.
Okay. And then 9375 explicitly references 9371, and 4062 states that the rates should not be contrary to other laws of the state of Vermont. So I just want to reference those two, 4062 and 9375. At least one explicitly references 9371, and the other one does through the provision of not contrary to laws of the state. So I just wanted to, I understand you don't understand exactly why these are not here, or what they are or they're not, but I just wanted to make that point. Thank you. And Mr. Barber, in terms of a public comment, I think there have been some members of public comment, so we might as well take public comment in case anyone wants to provide any.
Okay, if there are any members of the public present who would like to provide a comment, if you're on Teams, please raise your hand. If you're on the phone, well, start with people on Teams. If you're on Teams, please raise your hand. I'll call on you. Yes, Mr. Leclerc.
For the record, Alex Leclerc, Essex PT. Just one question. So I'm one of the people who gets a tax credit because I don't make that much money because my mom can't afford to pay me. So with the tax credit, does Blue Cross get that money? It's a premium, part of the premium. And if they don't, I guess that explains why we're in this situation. Yeah, that's just my comment.
Yeah, I
Can answer if you want, Mike.
I can try. If someone else can probably do it better. I think the premium tax credit, there's an option for the carrier to get it to lower the premium, or the member can choose to claim the credit when they file their taxes. It's so it's either of those two, depending on what the member chooses. But someone else can speak up and provide more detail on that. Anybody? Would anyone else like to make a comment who's on Teams? Is there anyone on the phone who would like to make a comment? Okay, I'll turn it back to you, Mr. Chair, to, I guess, adjourn the meeting or continue it until tomorrow.
Yep, I just wanted to thank the parties and the witnesses. There's a lot of questioning, there's a lot of time, some questions hard, and I just appreciate everyone's professionalism and the presentation by the parties. It was very, very helpful to me, and I'm sure the whole board. And I hope everyone can appreciate how difficult the situation is for Blue Cross and for the board and for the HCA and for everyone that has to pay these premiums. And I really appreciate the parties' opening statements recognizing that. And I do want to thank Blue Cross for its participation in trying to help solve the problems in terms of providing the board information and working with the board and hospitals and other entities to try and address this problem that we have. So I just want to make that remark, and I'll continue the hearing till tomorrow morning. Everyone have a nice night. We'll see you in the morning. Thank you.
Thank you.